My name's Brittany Poynter, and I'm the clinical head of the emergency department at the Centre for Addiction and Mental Health. So I think some of the barriers to identifying and treating people with substance use disorders, especially in the emergency department, is the shame that often goes along with substance use and substance misuse. Often patients aren't necessarily forthcoming with that information, and in a busy, chaotic emergency department, it can be challenging to take the time to take a thorough substance use history, especially if the presenting complaint was something else when the patient came in. In terms of treating people with substance use disorders, I think services need to be accessible and available to patients. When there are long wait lists or services are inaccessible, then sometimes those golden opportunities to stop that cycle are lost and patients relapse. So I think people often come to the emergency department looking for support because we are so accessible, and yet moving somebody through those stages of change in one interview can be challenging, and connecting them with the right service at the right time can also be a challenge. I think some of the most challenging cases for me are those where I have to play a role in reporting somebody to the Ministry of Transportation or Children's Aid, especially when it may be that person's first interaction with the mental health care and addictions world ever, and they've come seeking help, and I turn around and, in essence, betray their trust. And I imagine at times it can be triggering for a patient to have had that experience, and may lead to even more use of substances. And so then what good have I done them? As a health professional, it's heart-wrenching for me in the emergency department to have to tell a mother that I'm reporting her to the Children's Aid. And yet I do it on a fairly regular basis. When one has these interactions, I think the most important piece is how one frames the information. And if the communication about reporting somebody is done from a stance of care and concern and respect, then it is often better received from the patient. Sometimes I know that in the emergency department, I need to play the role of the bad guy, so to speak, so that a patient can move on to have a positive and trustful relationship with the supports they find in the addictions program. I assume that everybody walking into the emergency department has a concurrent disorder, and it's woven into my psychiatric history. In the emergency department, we need to be flexible in terms of the care we offer. So if somebody comes in intoxicated, we let them sleep it off until we're able to do a proper assessment. If somebody comes in withdrawing, then we'll manage their withdrawal symptoms in a safe way. Once their withdrawal has been managed, then we'll have a discussion with them about whether they're interested in further support. If detox is all they want, then that's okay too. So there's no standard or bar to determine who's worthy of services and who isn't when they come into the emergency department. We have to be flexible and offer patients what they need in that moment. And if somebody's motivated for change and we can have a discussion with them about that in the emergency department, then it's a victory for us. The advice I give the residents who I work with in the emergency department is to speak in a non-judgmental way. Assume that everybody has a substance use disorder or concurrent disorder, that it's the norm. And focus on what motivates the patient to stay sober, and help them grasp onto that, help them hold on to that as they move through their recovery. When I was a resident, I had 1 month of addictions clinical training in my first year of residency. one of my most memorable days of my entire residency was the day I spent at Seton House in their harm reduction program. That really opened my eyes to what it was like in the real world, outside of the confines of our hospital and our, safe and cushy environment sometimes. And I think as a resident and a learner, you evolve and you mature. Starting out residency, I probably had fantasies of saving people on a regular basis who I saw in the emergency department, and wanting to connect them with the services right there in that moment. And I know now that that needs to come from the patient, not me, and that sometimes if we take a step back and give the patient more room to decide when they're ready, it makes for a better outcome. So I do things differently in the emergency department now, and hopefully we're getting people to the right place at the right time.